is good. Hey, everyone. We're going to get going, and people can join us as they get here. I'm Kerri Miller. We're in Cannon Falls tonight at the Cannon River Winery for the third in our three-part series of town halls called The Rural Voice. I'm going to ask Tim Penny if he will give the welcome, and then John Munson from Compeer, I think, has some things to say, and then we will get started with the conversation. Tim?
All right. Thank you, Kerri. Appreciate you being with us in Cannon Falls tonight. It's my part of the world. Tim Penny, the president of the Southern Minnesota Initiative Foundation. The Initiative Foundation is one of 6 rural foundations, and we cover collectively the 80, hi Kyle, the 80 non-metro counties in Minnesota. We came into existence in the middle of what was then called the farm crisis. We lost tens of thousands of family farmers, sadly, during that time, and smaller communities across rural Minnesota were struggling as well. The McKnight Foundation helped to seed and fund the creation of these 6 rural foundations to invest in the economic and community vitality of our respective regions. Our foundation serves a 20-county region in south central, southeastern Minnesota. For me, it is an affair of the heart because when I served this area in Congress, it was basically the same 20-county region. Our board of directors is represented tonight by Javier and Cassie and Carissa. Thank you for showing up tonight to be a part of this conversation. But thank all of you for being a part of it. 2 years ago, I asked the Rural Policy Center to do a study on the cost of living in rural. I hoped it would show that you could get paid less in rural, which often is the case, but you'd still be money ahead because the cost of living is lower. And the study came back to prove my point. Cost of living in Minnesota is significantly lower, and then you've got the quality of life. So I wrote an op-ed for the Star Tribune, basically saying, you know, here's what the study shows. Cost of living in rural is great, quality of life is great, and especially in this post-COVID world where we've learned that many of us can work remotely, why not work in rural? But the one thing that study showed about the cost of living is that while taxes, housing, childcare, so many other areas were less expensive in rural. In some instances, healthcare can still be more expensive in rural. And I know that because I've got 20 employees at the foundation and we have to negotiate for reasonable health costs every year, and we've had to increase deductibles and increase our HSA to make it all work. So this series of conversations that Kerri has led is really designed to help elevate and amplify the rural voice on issues that are important to our future. In northern Minnesota last week, they held a conversation around education workforce. In central Minnesota, they held a conversation about entrepreneurship. But here in southern, we decided to choose the topic of healthcare. So you are the folks that will contribute to this conversation tonight. Let's do our best to get the rural voice on these issues out there. I want to thank Mayo for being a part of this tonight. They cover the ground here pretty well. The flip side of the cost of healthcare in rural is that, I'll just mention this briefly and turn it over to John from Compeer. 16 years ago, I lost my wife, Barb, to pancreatic cancer. But the one good thing about living in this region is that we had everything we needed through Mayo. And so I do want to say that while the cost of healthcare is a challenge in rural, we have great healthcare for those circumstances where it's needed, and our family certainly benefited from the access to healthcare for that circumstance. So again, this is your evening, and chime in, don't be shy.
Well, great. Thanks, Tim. I appreciate this. Tim has been a good friend. We've gotten, well, we really have the same missions. Initiative Foundation and Compeer do. But we're about financing agriculture, but agriculture doesn't succeed without strong rural communities. In fact, they're very interdependent. Some would argue that agriculture is even more dependent on rural communities because a lot of that income doesn't come from on-farm sources. It comes outside of agriculture. So we're here talking about all of these rural issues. But our mission is to enrich agriculture and rural America. That's really critical to us. So one thing I can tell you, if you forget anything that I might say, which would probably be most everything, remember this, that rural development, Colleen, is a team sport. It's a team sport. Colleen knows, the head of rural development here in Minnesota, and has been for some time, a true expert in the room. And so Compeer works closely with them, for example. We have other Compeer people here. We have the lead financer in rural America of rural hospitals and nursing homes, assisted living, and Bob Madsen here tonight. We have so many voices, but one thing I've learned about rural healthcare, it doesn't succeed without a strong rural community. And that means you have to have a strong Main Street. You have to have a strong rural economy. You have to have strong schools. You have to have good daycare in your community. You have to have everything. You have to think of healthcare. We're all brought in through the hospital. We'll probably all leave through a hospital, more than likely. And in between, we got to figure this out. So it's a team sport. Many of you represent different aspects of your rural community. We want to hear from you tonight. So Kerri, I know you're going to do a great job of pulling all that out from them, and I'm looking forward to it. I'm here to listen and looking forward to it. Thanks, Kerri.
Thank you. So tonight, as we tackle the third of these three town halls, I know that we're wading into rural healthcare at a time when it has undergone some consequential changes over the last decade, and I think we're going to talk about that tonight. Primary care doctors are in short supply in rural America. Hospitals are closing and merging. The University of Minnesota's Rural Health Research Center, and we have a couple of guests here tonight from the center, they report that pregnant women are seeing their OBGYNs less and they're utilizing ER services more because obstetric care in rural America is hard to find. This is not only about patients. I also want to talk about the toll on rural doctors. I was reading a 2017 Mayo Clinic study that was published in Proceedings that found 44% of the doctors surveyed in rural practices were showing at least one sign of burnout, and that was before the COVID epidemic. So I'm hoping you'll share some of your experience with that and perhaps some of the ways that you've learned to cope with that. So what does this mean for patients and physicians and the quality of healthcare in rural Minnesota? How are healthcare organizations responding to this with innovation and imagination? Has the pandemic that we're still coping with in some ways catalyzed some creative thinking for reaching patients where they are? And how are medical organizations responding to our mental health crisis? I don't think we can have a conversation tonight about rural healthcare without talking about mental health. So I expect that to also be present in the discussion. Pleased to say that we have doctors and healthcare professionals and administrators from rural health organizations, from Mayo, from the University of Minnesota. We have civic leaders here. We have people who are really committed to figuring out some of the challenges that are presented to rural healthcare. We also have an online audience tonight. If you'd like to submit a question or a comment in real time, you can tweet me. I feel like I'm on the air. You can tweet me at Kerri, KERRIMPR. That's on Twitter. Or you can email us at info@ruralvoice.org. So I'll be monitoring my Twitter feed when I have a second to duck out, and we'll be looking at the questions that are coming in on Rural Voice. Again, that address is info@ruralvoice.org. So I'm going to put Dr. Cahill here on the spot because I had a conversation with him before we started, and he told me some things that were pretty enlightening for where I wanted to begin the conversation. So I'd like to hear from you, Dr. Cahill, about whether your practice and your work, and you've been doing this, I think you told me, for 30 years or more, is what you thought it would be when you started out as a young, idealistic, rural family physician.
Yeah, I think it's pretty much, the journey is now in my rearview mirror more than it's in the windshield. But seeing what you wanted to accomplish and being part of a small town and providing services, and I was with a small independent hospital and clinic for 26 years, And the practice has now changed. I work for Alina in the Faribault Clinic, and seeing that transition is very different. I found that the best way to stay ahead of things was to participate in organizations and coming to forums like this to let people know that the rural part of Minnesota requires a lot of care and requires a lot of attention in some cases. And I also used to tell people when I was at the MMA or the Minnesota Academy of Family Physicians, my job is to remind you the state doesn't end at Burnsville. And that making sure that they take into account the limitations that we have in rural healthcare, and as a primary care physician, trying to make sure that we allow us to do what we can in the changing environment for reimbursements and cost savings and total cost of care concepts. It gets more and more difficult to do that in a rural community.
Have you seen, I mentioned that there have been some very consequential changes in the last 10 years. Do you feel like those changes have accelerated in, I don't know, the last 8 or 9 years compared to those first couple of decades that you were working as a rural family physician?
Well, remember when I started in family medicine in Blue Earth, it was Emmanuel St. Joe's in Mankato. It was a lot of smaller clinics in individual doctors providing care in small towns, and that has all changed. And I think because of the dynamics of how we train the people that work in healthcare now, that's really made a huge dynamic in being able to get people into rural communities and provide services in rural hospitals and clinics. Yeah, I think that's really starting to change. And as we see the transition more to cost savings and looking at total cost of care, you can only do that with larger populations, and that just doesn't work well in a rural community where you're trying to provide services and one bad case makes you look like you're an outlier.
I know there are pressures on doctors and nurses no matter where you work, whether it's in rural Minnesota or somewhere else, but I'd like to hear from another physician about how you've seen these changes. I'm going to come right across to here. How you've seen these changes either accelerate or kind of add dimension to some of the things that you didn't expect in the practice. So introduce yourself, if you would.
My name is Anne Luanjo. I work for Mayo Clinic Health System as a hospitalist physician, and I cover the entire Southeast. So that includes 5 of the hospitals, including Cannon Falls. Healthcare has changed a lot. I was just listening to my other colleague talk about his career, and next year will be 10 years since I finished residency, and a lot has changed in a short period of time. And I think for us who work in the hospital system, it was especially difficult. A lot of things were accelerated, such as our use of telemedicine. It's something we always hoped to use, we had plans to use, but we had to accelerate that to make sure that our patients had access no matter where they were. Our 5 hospitals are geographically not very close. And there are times when we have provider access in one location, but another location is just overloaded with patients. So we started using telemedicine more just to kind of help our colleagues across, allow us to see patients sooner, putting orders so that nurses can start taking care of the patients sooner. And, we've just kind of expanded telemedicine that way.
I'm curious about how you think the patients have reacted to that. I mean, do they see that there's upside to this, but are you also hearing complaints about, I don't spend the kind of one-on-one intimate time that I used to get with my doctor?
The response has varied, but surprisingly has been good. I find that some patients are actually quite intrigued by this thing we're doing. And I've been on both sides of it, where I've been the telemedicine provider interacting with the patient. And usually it's gone well. And the reason it works well is because the entire team is invested. So the nurse kind of helps us educate the patient on what we're going to do. And even though I'm not physically present, we still work as a team. So for me personally, it helps that I know a lot of the staff at all the hospitals. So we're still able to interact properly as we, help care for the patients. So generally speaking, it has gone very well. We do respect our patients' wishes, and if a patient really did not want that tele-evaluation, we would not do it.
I was talking with Mary. Where is she? From Gillette. Mary, I thought oh, geez, right by me. Mary came to our event in Chisholm, and we got into a conversation afterwards, and so I learned that she was a nurse. Tell us a little bit more about your work.
Sure, thanks. My name is Mary, and I grew up in northern Minnesota and had to leave the area to get a four-year degree in nursing. So that was part of last week's conversation because there wasn't those educational opportunities several decades ago. And I kind of live in both worlds now in that I live in the metro, but I supervise the 7 clinics that Gillette Children's has around the state. And it's for kids and adults with special needs because my heart is in rural Minnesota, but I kind of juggle between the two. And again, it's to make sure that those patients get their needs met. We're specialty care, but yet we need primary care. And so when you talk about the telehealth that you, or telemedicine that you did, you need to trust that nurse or the person presenting the patient to you. And so how can we work together across health systems? And while you were talking, Anne, it kind of, again, I don't want to side rail your conversation, Kerri, but you know, when we come from so many different health systems, but our EMRs don't talk. And I know that there are ways, but it's such a challenge all the time. A couple of weeks ago at our clinic in Mankato, we were seeing a baby for plagiocephaly or craniosynostosis. Getting that initial growth chart is very important, and it was a struggle. And it was just, so again, that's one of the barriers that I see to be able to provide that care, because none of us are experts in everything. We need primary care, we need specialty care, and how can we work together?
Mary, one of the things that you mentioned early in our discussion was a patient, I think, who you expected to see at the Duluth clinic today, and that person just didn't have a ride in. I think this kind of exemplifies some of the concerns about, further distances to travel to get to these clinics and hospitals.
Duluth is one of our locations where we have a clinic, and an adult patient who lives in a group home couldn't make that appointment because there wasn't enough staff in the group home. So again, we have to go outside of healthcare and all work together, in communities so that they can get their needs met. So
I'd love to hear someone on what it means for the patient population to have to drive. Maybe Dr. Albright, I'll come over to you on this. Have to drive further, have to decide whether this is really worth the 50-mile trip to get whatever it is looked at. And some of that is just because some hospitals have closed, people are living further out. What would you say about that?
Yeah, thanks, Kerri. I'm Bob Albright, and by trade, I'm a nephrologist, which makes me a kidney doctor. But I also serve as our regional vice president for Southeast Minnesota. And this is a crucial matter. And it's not been that long ago that gas was unaffordable. And I had patients really trying to decide if they were going to be able to come to dialysis.
Wow.
And as you know, dialysis is life support. But more importantly, from the healthcare system, that's kind of our goal. How do we get patients the care they need where they're at? How do we meet our communities where they need to be met? And this is a really deep bit of work for us all to do, and very good work to do, for sure. The big issue is how do we move the mountain to the patient and not vice versa? So, looking at things like mobile clinics, or looking at different ways to do rehab, or looking at different ways to allow the patient to interact. And as Ann Luanjo highlights, and Dr. Cahill too, it's just a different ballgame now. We've got patients that are all totally in. They don't ever want to talk to another human. They want to use their app. They're fine with a bot. But we also have another dichotomous population that will only be comfortable sitting face-to-face with us. And how do we fine-tune that experience for both of these groups of patients? It's great work.
Dr. Albright, what do you do? How do you balance the reality that running a hospital is expensive? A lot of hospitals have closed. Organizations like Mayo have come in to run some of these hospitals, but that might mean that there isn't a hospital in every community. How do you balance the reality of the financials of rural healthcare with access to healthcare when you need it for people that live in outlying communities?
Yeah, it is the vexing question for us as a society to deal with. So I think it's important we put the patients always at the center. Again, what do our patients need? What is that going to provide our communities what they really, really, really deserve? So if we look at our community assessments, it's always the top 3. behavioral health, mental illness, substance use or abuse, and of course, equities and disparities in care. So we put the patients at the center and then decide how can we best serve the patients with this value equation. It's going to cost a lot, but how do we also avoid the costs that will be inherent if we don't provide that cost? And we have a very special responsibility as Mayo in this region, because in a sense, we do a lot of the longitudinal care, if not most of it, for many of our community members. And I'd say that we have to get this right, because how do we get people to want to live here? If folks live here, they'll work for our industries, they will work for our healthcare systems, and we will train the best and brightest and continue to be the destination for people who want to live in our communities, not only just a destination medical center. So it's imperative that we get this right.
Tim, will you speak to that?
Well, I think John said it best in his opening remarks, that living in rural, there is a quality of life. In most respects, the cost of living is lower in many, many categories, housing, et cetera. But if we really want to have a future in rural that is optimal, there are some areas that we need to address, and access and cost in healthcare is one of those. And so I appreciate the fact that we're doing these rural voice conversations, because this challenge is different, and it has to be addressed differently in rural than we might propose to address disparity issues in the metro area. And we'll only get to a solution with conversations like this.
I'm looking for Bob from Compere. There he is. Bob, I'm going to come back to you, because one of the solutions that Compere is working on is funding independent health organizations. Will you talk a little bit about that while I go see if anybody's tweeting in?
Yeah, absolutely. So for the last probably 15 years, Compere has been financing either the replacement or kind of major renovation expansions of critical access hospitals and senior care facilities. But one of the things that we've seen is communities really deciding what are their needs maybe versus their wants, and really focusing on the needs first. Obviously, the cost of these facilities, especially in today's environment, is just skyrocketed. So that's even more important. But every time that we're looking at one of these facilities, we're looking at a lot of demographics. So it's projecting population decline in rural, also the aging rural community. So that means the people that live in rural are older and sicker. So it's evident that we need the facilities, we need the ability to provide that care, but yet on the flip side, we need to have these facilities to even have an opportunity to attract younger people back to rural America, to have that Main Street, to maybe try to change those demographics, because without these facilities, we really don't stand a fighting chance, of keeping rural America vibrant. So that's the focus of what we do, and it's an extremely important issue.
I just have a follow-up question. How do you decide? I mean, that's a big investment to come in and say, we're not only going to get you off the ground, we're going to make sure you succeed as an independent healthcare facility. How do you decide who's going to get that funding?
Well, it's really a combination. Obviously, there's financial metrics at play, but we examine those rural communities too. What do they have for an employment base, an agricultural base? Is it stable? What kind of volatility do they have? But it's also, think about physicians and specialists. Do they have affiliations with larger systems? Is it a really strong one or something fairly loose? Are they able to recruit and retain physicians? Because without those professionals, you don't have a healthcare system. So there needs to be access one way or another. But I will say there is not one model that definitely outperforms one versus the other. Every community is a little bit different, and it's really just the totality of the circumstances.
Thank you. I'm looking for our guest. I saw her when she came in, Kerri from the University of Minnesota. Where is she? Oh, yeah, I'm going to come over there. I'm curious, Doctor, about so far you've heard a conversation that I'm sure is pretty familiar to you. Patients are driving further. Some hospitals are closing. How does How does the policy response look to you? Is it sufficient? Are you seeing enough innovation to meet the need? Introduce yourself if you will.
I'm Kerri Henning-Smith. I'm the Deputy Director of the University of Minnesota Rural Health Research Center, and I'm on faculty at the University of Minnesota School of Public Health. And my colleague, Dr. Katie Bacchus-Casamano, is over there too.
You made it. Yeah.
So she can also speak to this. I think that we've heard so many different issues. Health and healthcare are not just about what happens within the clinic or hospital setting. They're about the economic situation in the community. They're about transportation infrastructure. They're about access to broadband internet and whether you can use telehealth with that. And I'm seeing policy responses to all of those, but I think we would all agree that we don't have quite enough yet. There's still enormous need. There's still incredible inequities on geographic lines, and then between rural populations too. We've talked about rural as one big population so far, but there's a lot of diversity and a lot of inequity between rural residents, and I think there's a long way to go to meet the need through policy and through programs.
I think I hear you saying, and maybe your colleague, the director here, will echo this, that you have not really cracked the code to figure this out yet. Is that right? If you'll, welcome, I'm glad you made it. Tell us your title and then I'll ask you a question.
Hi, Kerri. I'm so glad to be here. I had a little trouble getting here, and doesn't that just exemplify? We all know. So my name is Katie Bacchus-Casamano. I'm the director of the University of Minnesota Rural Health Research Center. A proud person who is from rural Minnesota and continues to love greater Minnesota. And I love this question. I also love this conversation. It helps the work that we do at the University of Minnesota, which is we conduct research on rural communities across the country. But the right questions to ask are the ones that people in rural communities are asking. And I think there's a disconnect between the experiences of rural people and rural clinicians and the understanding of policymakers about what needs to be done. Most of our policymakers at the federal level have lived and spent most of their lives in urban areas. Most of our clinicians are trained in urban communities, and most of the research that we depend on is conducted in urban areas, excuse me. And so in order to understand what rural communities need, we need to hear from rural people. Kerri mentioned a lot of really valuable areas of policy investment. And I think it's important, it's wise to distinguish policy that is broad economic development, rural development policy from healthcare access policy. And within healthcare access, thinking about the layers of access to care. Are we talking about hospital and physician care? We do hear a lot about that. It's extremely important. We also need to talk about access to nurses, recruiting and retraining nurses in communities. Is there childcare in communities? Is this a place where you can build your family? Is there a school? And all of those things are interconnected with one another. Obviously, policies need to take things one step at a time. And we're seeing investment in the Rural Emergency Hospital Program as an innovative strategy to invest in making sure we have emergency care in rural communities that are otherwise without access to emergency services and other important things. I'm thinking of two people that I talked to right before we started here who are here from a hospice organization who also talked about, I think, who speak to the complexity of what you've just mentioned. It's not just about whether there's a physician on call when you show up at the ER. Will you two introduce yourselves and tell us a little bit about what you do?
I'm Laura. I'm a registered nurse with a hospice, and I have lived in Cannon Falls for 30 years. I serve the communities of Northfield, Faribault, Red Wing, and Cannon Falls.
I'm glad you came.
My name is Ken Nelson. I am a nurse RN case manager with a hospice agency as well, serving similar communities as Laura.
So Laura, when you hear our other audience members here talk about this is so much more complicated than just, can I see a family physician when I need to? I think you kind of exemplify, are there going to be people there prepared to care for you with the kind of skills you need at the end of your life too? It's not something we talk that much about in rural Minnesota, and I just love to hear your experience with this.
I think for us, it's a little bit different because we go to the patient. So it's a little more taxing on us. The drive time, living in a rural community, do we want to drive to the metro for a job? So I think for us, it weighs a little bit heavier on us as clinicians.
I would agree, having worked in a more rural area and currently helping out in a metro area, there's definitely a difference, having to drive, 20, 30, 40 miles between visits really cuts back on the amount of time you have to, get your documentation done. Whereas in the metro, if you have to go to multiple places, you might only be a handful of miles away, and it gives you more time to complete that sort of unseen work.
And I think also you're spending less time with the patient because you're having to navigate and drive. So families are probably receiving a little less end-of-life education, or we're not quite spending as much time with the patients that we'd like to.
Are there enough nurses who do the kind of work that you do? And, what happens if somebody quits? Is it hard to replace them?
Just because we're going through this, but I think in our area, it is really hard to find people that are very passionate about hospice care. I think it's a challenging place to be. So I think that, when things turn over, then it kind of lands on us again. So we're having to see more patients, more visits, and in turn, the patient and their family might be receiving a little less than we would like.
Can someone else speak to, again, you can solve one problem, but there might be 9 more that you have to get out to really find good solutions to this? I think I'm going to come over here to our Mayo row. She's like, no, she's coming to me. Yes. Introduce yourself, would you?
So I'm Megan Johnston-Flanders. I'm a family physician here in Cannon Falls. I've been here for 11 years and live in the community as well. And I don't yet know if I have an answer to your question.
Reflect on it if you would.
So lots of challenges listening to hospice talk. I work both in the hospital and within the clinic. I'm still a rare physician who does that. And when we have patients in the hospital, we're having troubles discharging them. We're having troubles getting them the services that they need because there aren't enough staff at our home health care agencies to take them. And so that's really leaving a gap in patient care when they leave the hospital very vulnerable. And as we were talking about communities getting older, family members now maybe don't live in the same town. And so now we're relying on patients' families that are out of town and we can't get that safety network around them. Mayo really tries to have our patient care, coordinators who follow them when they leave the hospital. If they're high risk, they will do home visits to try kind of bridge that gap. But it's definitely a challenge.
I want to throw this statistic in to the conversation and ask some of the kind of hands-on healthcare providers to think about this. Before the pandemic, a poll from Harvard and the Robert Woods Johnson Foundation and NPR came out. It found that 1 out of every 4 people who lived in rural America could not get the health care they needed when they needed it. And many said, it's too far away. Some said it's too expensive. Some said the experience, if I have to drive and it's 50 or 60 miles and then I sit there for another 2 hours, just the experience of trying to get that health care was somewhat demoralizing. I see you nodding with it. You've heard, yeah.
Yes, so
Introduce yourself.
Anne Luonjo, I am a hospital medicine physician. I also serve as the vice chair of hospital practice for Mayo Clinic Health System in Southeast Region. And I used to practice similar to Dr. Johnston. So when I started working in the health system, I worked as an outpatient provider and a hospital provider. And back then I worked in Wabasha, which is a very small community. And it was interesting for me leaving Chicago, coming to Lake City, working in Wabasha, and I would refer my patients to go see specialists in Rochester, and they'd be like, oh, that's too far. There's traffic, there's parking. I was like, no. I'm thinking about how Chicago is like. I was like, well, this is nothing. But, just appreciating some of those, limitations, elderly patients, driving there, having access. And I think, in a way, that's part of why I enjoyed that practice, because I felt like it challenged me to do more, to think more, to learn more. Over time, we've really worked with our specialist in Rochester to help, improve that access, even if it's just virtually, both in the outpatient and inpatient world, having electronic consults, where, we can just put in an order, that specialist reviews the chart and gives us some input so that we can continue caring for that patient locally. So we have that option in the outpatient. In the inpatient setting, it could be a similar e-consult, but it could just be a phone call. I need to have a cardiologist look at this EKG real quick and let me know what they think, see what I can do to continue to care for this patient exactly where they are. And that, that practice has grown a lot, and it's something that, we, the community providers, really enjoy having that access to other specialists, because we value what we do and we want to keep our patients locally. And also when it comes to, follow up. So there are patients who have to go to Rochester for certain procedures or for like chemo, radiation, whatever it is they need. But now they can, live in their community, go to their local hospital, get blood drawn. Their provider in Rochester is going to review the results. They're going to send them a message on their portal, or give them a phone call, instead of driving back and forth just to get a blood draw, just to get an imaging, or sometimes just to get an infusion. As much as possible, we try to keep that local and help the patients get that access, and just to empower us providers to continue to care for our patients locally.
I'm going to come right over here. Introduce yourself, if you would. I'd love you to reflect a little bit on that question.
Yeah, my name's Ulrika Weigert, and I'm a family practice physician in Sauk Center, Minnesota, and I've been practicing there 20 years. Broad spectrum clinic, hospital, OB, ER, nursing home practice. And then I also dabble in a little administrative, overseeing some of the rural practices within CentraCare, which is the organization in central Minnesota. And I think there's this balance, like you're saying, we're trying to keep patients close to home and provide the level of care that we need. But I have been really struck by what's happened through this pandemic, and I've been struck by how fragile our healthcare system really is. And when COVID was bad, we had a hard time moving patients to the level of care that they needed. We couldn't get people from our small rural hospital to the bigger hospitals, and needed the ventilators and the ICUs, and we didn't have the beds. And COVID's better. We aren't seeing those sick patients, but we still have problems. And the problem that we're dealing with right now is the staffing issue. So right now we're still dealing with very sick patients in our small facilities that we are trying to do telehealth and trying to do the level of care that we need. But they need to be in a bigger facility, and there isn't staffing at those bigger facilities to be able to take those sick patients.
So do the bigger facilities, the bigger hospitals tell you, no, we simply can't admit them?
Yes, it's very tiring to have to call many, hospitals all over the entire state trying to get a patient to the level of specialty care that they need. And it's still happening now. And it's one of these things that we're working as organizations to try to strengthen our smaller facilities and be able to provide levels of service that we never had to before this pandemic. And we're doing better. But until we fix the staffing issues, which is probably the biggest problem in rural healthcare right now, we're not going to get this all fixed. And part of it's providers, part of it's nurses, all levels that are needed. And it's great to live in a small town. I grew up in a small town. I chose to work in a small town. And people like that. But it's a lower cost of living, like you said. But right now, people commute. They can commute to a bigger facility, get paid more, and maybe have a different lifestyle still in the small community, but we have to compete with that level for staffing.
come right here to introduce yourself, if you will.
Hi, Kerri. My name is Cindy Perkins-Smith, and I'm a dermatologist in rural Minnesota. I've worked for 3 decades in Wilmer and Litchfield and Painesville. And I'm also Senior Vice President of Rural Health for CentraCare, so I am all about rural. And listening to Ulrika and listening to other people talk about staffing really brings that home for me, because the minute I moved out to Wilmer from the University of Minnesota, I started recruiting for another dermatologist. And I've never stopped recruiting in 32 years. But I will tell you that what happened with the COVID pandemic really moved things to crisis level for staffing. We have seen a lack of staffing at every level that we have never seen before. And I don't know if people understand the statistics, but you can look at a variety of different data sources. But there's data that suggests that over half of rural physicians in this state are over age 58. I fall into that category. We're not going to practice forever, all right? And we're not seeing enough young physicians coming up to replace us. The truth is that we don't have many rural students going into medicine. Less than, the statistic was like 6% or 5% of medical students are from a rural location.
I've got a little number here for that. 2019, research group called Merritt Hawkins surveyed medical school students in their last years of med school. Only 2% said they wanted to live and practice in communities under 25,000 people.
And let's talk about that. How do we replace rural physicians that are going to be retiring when 2% of medical students want to practice in rural areas? That is a crisis. We need to work with grade school students, junior high students, high school students. We need to figure out why they're not going into medicine. We need to figure out why they're not being accepted to medical school, because they are not. We need to address those levels throughout healthcare and get some of those kids to come back to rural areas and take care of the people that we need to serve.
So that's long range. What about right now?
Good question. What about right now? What type of financial incentives can we create for those students coming out? We know that physicians and everyone in this room is in healthcare are driven by purpose. We are here to serve people. But at the same time, medical students are graduating with debts of $500,000. You know, purpose can drive you, but at the end of the day, you've got to pay to feed your family and house payments as well. What type of incentives can we create for some of those students with debt burdens of $500,000 to come out and serve our rural communities? I think we can help with that.
John, I'm curious about whether, I mean, you've got a wide portfolio. I wonder if you think about these kinds of questions as you think about costs and access in rural Minnesota.
Well, she's got me thinking right now. I'll tell you that.
What are you thinking about?
Well, what we're thinking about, so we do provide a lot of tuition assistance for a number of different students, especially as it relates to agriculture, but she's got me thinking about broadening that out. You know, what do we do? What do we do differently? How do we challenge ourselves in a new way? We provide a lot of grants, donations, and scholarships for a multitude of reasons. That's a big crisis you've just pointed out, and so you really have me thinking about what can we do to help be part of that solution. But I think it's going to take more than us. It's a team sport in rural America, as we know, and it would require many challenge grants. Tim, we've used them, and we can get those kinds of things rolling to help out. But I mean, this is an important conversation, and you're right, it's a crisis, and I appreciate hearing more about it.
So how does something like that sound to you? I mean, that's kind of on the ground problem.
We'll change deets. I'll give him my phone number and we'll talk about it. Because we are all into collaboration. We're looking at the opportunity out in our area of what it might look like to collaborate on a medical school. You know, what might that look like? And you're right, that's long term, but we've got to start somewhere. The best way to create a rural physician is to give birth to them, raise them up, educate them, and bring them back home. But we can't raise up enough rural people to serve our people. The next best way is to educate them in rural areas. If you think that we're going to get rural physicians by educating them, no offense, in Minneapolis, I love Minneapolis, but if we think we're going to educate rural docs in Minneapolis and expect them to move out to our rural areas, it's not going to happen. Data is very clear. We need to educate them in rural areas. And they'll discover why we love it, and they'll stay.
Right back here. Yes, ma'am.
So a couple things to add. Not only do we have to support the physicians and the providers coming out, but it's also their spouses. And I myself am from small town North Dakota, and it was my goal to always go back to my hometown and be a doctor. And I met my husband in medical school, and he said, we're not living there. It's either me or North Dakota, and I chose him, and so here I am in Minnesota. But when we were trying to decide where to go with our lives, he wanted urban, I wanted rural. And so we were looking on the outer rim of the Twin Cities so that we could serve both of our interests. In my hometown, Grafton, North Dakota, 4,000 people. I still follow them in their recruiting efforts. And when they were recruiting one of their physicians, their whole town started sending letters to not only the provider, but also to the provider's spouse to make them feel wanted within the community and to show them everything that their community had to offer. So we can't just think about the one person, we need to think about the pair. And then also talking about being interested in working in a rural area. So I did grow up in a rural area, and I still had a narrow view of family medicine. I wanted to be an orthopedic surgeon coming out. But in medical school, I was part of Rural Opportunities in Medical Education, which is what University of North Dakota offers for their third year of medical school. I actually lived in a hospital for 7 months and was part of their community. And it was an amazing experience. I mean, when the code siren went off in the middle of the night, when there was a trauma call in the middle of the night, I was on site, and I got to go down and be a part of that experience in the ER. I delivered my first baby as a third-year medical student because the physician didn't show up in time, but because I was on site. And this is a person that I knew because I had seen her in clinic already. So for those 7 months, you had continuity of care. You got to know your patients. And to have that experience really shows you what it can mean to be a family physician. And I mean, just the relationships you develop are what, to me, medicine is about. And so that was a great opportunity that I think really opened my eyes to what being a family medicine doctor could be. And again, I'm not an orthopedic surgeon, so it really helps you change my perspective on what being a rural doctor could be. And I think University of Minnesota and both Mayo kind of have a similar type program that they offer, RPAP and CPAP. But I just think, yes, having those opportunities really does open up the eyes to patients or to students who don't know really the breadth that family medicine has to offer.
We have a question from someone who is watching on the stream. And by the way, if you'd like to submit a question in real time, you can do that. info@ruralvoice.org, or you can tweet me at Kerri, KERRIMPR. Here's the question from Rick. How can medical, nursing, or pharmacy boards be challenged to grant an expansion of the respective scopes of practice to help meet a need in medically underserved areas? I was just reading an article about this in the New York Times over the weekend. Dr. Albright, what I was reading in this piece was that doctors are really fighting this. Is that true, and why would that be?
I can't imagine that would be the case. How could that possibly happen?
Right.
Well, I think this dovetails nicely into our other discussions of why do people choose what they choose. And we just heard that, it's, to quote some of those politicians, it's the economy, and I won't add the other word, but it's really important that you recognize how you have to meet these providers as they come forward. And there's so much opportunity that we can afford to expand up to the scope to even use what we have now. I don't know that we necessarily need to change things, but just get folks up to the scope that they could practice now.
Okay, I want to make sure I'm understanding what you're saying. Are you saying, yes, we could allow people who do not have MDs to serve in larger capacities in some of these rural areas to meet the needs that Rick is talking about, or no, that doesn't work?
Well, I think it's true, but you need to stay within your licensure goals and within your licensure boundaries. And I mean, before we take on the big issue of changing licensure, I think allowing folks to work right up to that with appropriate supervision are areas that we could really work together on. I'll give you an example. Many areas have deployed this, where community paramedics are now going out and providing continuity of care. You would not expect that individual to prescribe medications or maybe even dictate care pathways, but that individual is much more skilled than a layperson, and they can really expand the capacity of the team so to speak, to get that patient the care they need in their local area. And it makes me think a little bit about the unintended consequences you mentioned earlier too. As we talk to our paramedics about doing local care with our patients and they're traveling large distances to see their patients, then wait a minute, is that rig, so to speak, available when someone needs them elsewhere? So we've got these finite resources, and we've got folks that we can really deploy in novel ways to help them work right up to their scope of licensure and really expand the capacity of our system.
Who else would like to speak to that because I'll come to you if you, Dr. Cahill, I'm going to come back to you. What do you think about Rick's question there?
Well, I think I've seen the expansion of nurse practitioners, physician's assistants, and trying to get RNs more involved in care. I also do some hospice work as well, and having nurse practitioners do face-to-face visits is part of the organization. So you used to be where you'd have a physician going out and doing those services, and we've learned to expand what people can do with the skill set. I sit in a room with a nurse practitioner and a physician's assistants who do things that I think some medical students would be very uncomfortable seeing and doing, but they have the experience and they have the support to do it. And I think maximizing what we can do with the resources available, patients want to be able to come in and talk to somebody who cares about what happens to them. That's the bottom line. And if we provide the support for the mid-level practitioner, the advanced practitioners, that's going to allow us to do more services. But it's stressful to be a physician in rural Minnesota because you're the top part of that and you get the difficult things to do. And if you don't have a lot of physicians to share call, it's hard to be on call all the time and add in if you're in the hospital and the ER and delivering babies and going to the nursing homes. And I did that for 20 years. It's very difficult to maintain a lifestyle that's comfortable. And I think some people now coming through medicine just look at, I can't do that. I don't want to do that. And we need to respect their look at maintaining a lifestyle that's appropriate. And how do you match that with the needs of a rural community? And I think that's really a lot of the crux of what we're trying to get at is give people what they're looking for, which is personal care, and yet not burn out the people that are trying to provide it.
One of the things that used to come up when I was having conversations about healthcare policy was managing costs and managing patient expectations. What was really required to solve whatever issue it was, but how to tell the patient you really don't need that MRI yet for the back pain. I'm curious about how that works in rural Minnesota when you may be the doctor that they've seen for the first time in 6 months or a year or a couple years. I'm going to come over to you. You're nodding, going, yes, I deal with that.
I had that conversation today with a patient. Yeah.
Can you, without divulging anything, tell us a little bit about how that went?
Well, it goes back to our training and what's the best practice and what does the evidence show? And it's about having that communication with the patients. And I think in a rural practice, there is a unique way that we know our patients better. And so I know my patients very well. And so that allows me to communicate some of the medical parts of it at a different level when I see them in the grocery store. Their kids went to school with my kids. And so it's very unique in that way that you can sometimes say, it's okay to try this first. It's okay that we will do your MRI if this doesn't happen or that doesn't happen. And come back to me knowing that you will have that follow-up relationship with patients. And that is the unique thing about rural medicine that I think is different than a specialist in a cities that may not have that same continuity with their patients. So that's why I enjoy it, and that's why I stay in rural medicine. And that's why I wouldn't want to be in a practice where I don't know my patients the way I do now.
Let me come back here to the back. So we've talked about managing costs and managing patient expectations, but also whether policy is rising to meet some of these challenges for managing costs. And I'd love your thoughts on that. If you'll reintroduce yourself.
Sure. I'm Katie Cosimano at the University of Minnesota Rural Health Research Center. His policy rising to the occasion to address costs. Oh, goodness. I mean, it's very difficult because the way we pay for healthcare in the US is an urban-based, and it's a fee-for-service. It's sort of basically you get paid money based on the number of people who walk through the door, and in rural places there are fewer people who come through the door. So it's very difficult to make ends meet. And hospitals are always faced with trade-offs because they want to keep the door open to keep access for folks in their community. But and we have programs, we pay differently, for example, for critical access hospitals in the US, and there's evidence that shows that that program has kept hospitals open in communities. But there's a need for a lot more than what is currently being done, and a lot more thoughtful ways of supporting the higher fixed costs that rural facilities face. I do a lot of research on maternity care and obstetric units, and that's a great example of you need to have certain things in place to be able to be ready to take care of a pregnant person and a baby coming at any time, any day or any night. And we have hospitals that have 20 births a year, and it's really hard to keep a unit open and pay for it. But if you're in a very isolated area, you need to be able to take care of that patient if they come through the door, if labor is precipitous and they're going to have a baby. And that's something that we haven't figured out how to finance very well yet. There are a lot of ideas, low volume payment adjustments that could be addressed, but those are also kind of retrofits. They're plugging holes. They're not changing fundamentally how we pay for things. Even someone else was talking about the value-based payments. And again, when you have small numbers, and you care for a population of folks that may be sicker or may have higher risk factors, may not get care as often, you're more likely to show, quote, low quality care on these metrics that, again, are predominantly created in urban communities, in academic health centers. Many of our credentialing entities are using quality standards that are not always rural relevant, because you don't even necessarily have the volume to be able to do that at the, provide the particular type of service or have something available that might be considered kind of a basic level of care. But that's not how we roll in rural all the time. We do what we can with what we've got, and we do really well, but that doesn't, the money doesn't come in for that.
Tim, I wanted to come back to you and just ask you about the Affordable Care Act, which I know is an ongoing process and, has created some problems and solved others. Has the Affordable Care Act overall done what it should have done for rural health care? Or are there a lot of really serious fixes that the ACA could address?
I think it should have been renamed the Accessible Care Act.
Yes.
Because it didn't really do anything to control costs.
Right.
So, and actually, if you're running a small business, and I would say our foundation is a small business, we got 20 employees, we saw costs double in the first few years of that law. For healthcare, for coverage. And so we had to make adjustments, did as best we could, but increased the out-of-pocket costs for our employees, tried to backfill that with an HSA. It's settled out now, but that was the initial implication. So affordable in the sense that it made subsidies available for lower income people, and that's a great thing, but not affordable in terms of controlling costs of healthcare.
So that was a big no on what the ACA could have, your own experience, but overall as well.
Well, give credit where credit is due. It expanded coverage significantly, and that's a good thing. Some states went along with that, other states didn't. Minnesota went along with that. Right. I would leave it to the health professionals to talk about whether what we had before the Affordable Care Act was better than what we have now with the Affordable Care Act, because it replaced Minnesota Care, And there may be some opinions about whether that was the right trade-off. Maybe we should have been allowed to use the resources from the federal government to just supplement what we were already doing in Minnesota. And I think that it's, it's water over the dam now, but this was kind of a one-size-fits-all subsidy system for the nation, and it might have been better if that had been more flexible, so that in different states with pre-existing accessible care programs, we might have been able to work with that.
Dr. Albright, you have a view on this?
Well, I would say maybe, thanks, Kerri. I would say one of the things that we haven't talked as much about, we've focused a little bit on policy and we've focused on our providers and also our nursing staff, but we haven't talked a little bit about prevention, a whole lot about that. And I think acknowledging the challenges that we all face with the obesity epidemic, diabetes, hypertension, and how these are bellwethers of societal issues that are what we call social determinants of care or social determinants of health. And boy, if you think about where we really ought to be directing our efforts, one would argue that from a value perspective, we really ought to be focused there rather than treatment. Now, we all know that that's a big opportunity, and the ways we do this are myriad and challenging. There are some new pharmaceuticals that are available, but that's not really where we ought to be going. We ought to be looking more at food insecurity, which I know we need our community partners, and we need our faith-based organizations, and we need our entire community to get together about those things. And I'm noticing the facial expressions here, and I might give it to you, Doctor.
We're going to get very political very quickly, I think, on this topic. The United States is very good at sick care, not very good at health care. So we're paid right now. It's the only country really where we get paid for not providing great care. If I take care of a patient and mess up, I not only get paid for taking care of the patient the first time, but a lot of times I get paid for taking care of what I messed up as well. So I get paid for the more I do, the more I get, right? Well, we need to get paid for keeping people healthy and providing really high quality, really safe care. And it's not the way it's designed. So in order to really invest money to keeping people healthy, we've got to disrupt the way we pay people to do it. And that's a really big politically charged problem in this country.
We have an online comment here from Lisa Archer. She is the Chief Nursing Officer at Southwest Wisconsin Region, and she is responding to what we were talking about when it comes to staffing. She says, all of my colleagues have stated the many challenges for rural health care well. As a rural health nurse leader, my challenge is to recruit healthcare professionals to rural community practice. The young doctors, nurses, dentists, paraprofessionals, and others are difficult to attract to small communities, pretty much what we've heard tonight. These communities have and need specialists who require RNs and other support staff to provide care. How can we use, she says, seductive tuition repayment programs and payday salaries that are competitive to sway healthcare workers into rural care? How can we assure them that they will be challenged, fulfilled, and used their education to cure and transform the lives of others? That's a really good question. Who would tackle that? Yes, ma'am.
No pressure here. I'm actually doing some work in partnership with the Minnesota Department on Health, looking at all of the licensure data that all of you who are licensed clinicians submit every year, or every time you re-up your license. And part of that is to see what incentives actually attract people to work in urban and rural areas. We're asking them, and we're finding the financial incentives are effective and helpful, but they're not the only thing. They're not even the main thing. Some of the other reasons that people have mentioned tonight are more attractive. Having grown up in a rural area is by far the biggest predictor of rural practice. And so getting those educational programs into rural areas at really young ages, talking with little kids about healthcare careers is really powerful, and talking with them about the broad spectrum of available careers is really helpful.
but then ensuring that they have opportunities to train at all levels in rural communities. And we've heard some examples of that from North Dakota and the U and Mayo. There are other nice examples of that. Wisconsin has a great obstetrics residency program, but getting programs like that for nurse practitioners, for PAs, for RNs, for people at every type of practice, every level of practice is really important. And then we're also finding in the data that rural providers in particular really are attracted by being able to practice the way they want to practice, by having a broad scope of practice, by seeing a lot of patients and having a continuity with those patients. They might see the same family members. And so I think to the question that was asked, how do you convince people that they're going to be able to do meaningful work? I'm paraphrasing, I don't think that's exactly what the question was. To me, that feels like a no-brainer. That's the easy sell. I think you're going to do really meaningful work. You can also be a neighbor and a community member with the patients you serve. And I can't think of anything more meaningful than that. So I think it's about messaging, and messaging starting at really young ages to get people interested.
We've been going about an hour. I don't want to end the discussion, though, without talking about mental health, because I had a conversation with a child psychiatrist who was getting close to retirement. He happened to come to our discussion at St. Joseph, which was about entrepreneurism, but he was there and started describing his work. And I mentioned that we were going to be doing this conversation, and he said that it is just an absolute crisis levels out here in rural Minnesota. Dr. Albright, you have a thought on that? Okay. What is the answer? I mean, these kids, the way he described it, need help now. Some of these, again, are long-range solutions, and they sound good, but what do you do about now?
Yeah, this is truly a crisis, and we're seeing it in our rural emergency rooms where folks are boarding, where our children are boarding, and even finding mental health beds anywhere in our region, our state, is impossible. So it's a total crisis. There's some novel things that have come up. The Rochester Crisis Center, that was a joint work done by Senator Senjem and the communities. That serves a bunch of our counties. I think 800 patients have received care there, roughly 800. It's a drop in the bucket, though, honestly. We need 4 times that. And it's really sobering to acknowledge what kind of investment needs to take place. And this is prevention, but it's also the treatment aspect of this. Top to bottom, behavioral health, substance use and abuse, just our number 1 and number 2 at every single community needs assessment we do in the state. And we need to get the attention of our policymakers and do the research and come forward with a plan that really puts our money where our mouth is.
Why is funding difficult to get? And I know it's not just crisis mental health issues, but across the board. Doctor, can you speak to that?
I'm not sure I can really speak to the funding per se, but one thing I wanted to make sure we also address when we talk about mental health is also for the providers. So it's the person who registers the patients, it's the CNAs, the aides, the people who take the phone calls, the nurse on the phone who's taking phone calls for patients. COVID has really put a strain on the entire system. And interestingly, one of my colleagues mentioned, top to bottom, our environmental services team, they're short-staffed. And I think it's important that, as providers, as leaders, we acknowledge what we're all dealing with and that we're honest about what we do. We have had difficulty getting patients to the right locations when they need, just like my other colleague has mentioned. One of the things we did is just created like a central transfer center. So instead of calling 20 hospitals, you can just call this one person to kind of help do all of that. But
It's like an air traffic controller, kind of.
yeah, but that still means the patients are staying in the ED or in the hospital longer. So that ED provider or that hospitalist provider who's not really accustomed to taking care of an ICU patient is keeping that patient even longer. And also being mindful of how this is also impacting our community, right? So our community ambulances are having to drive even further to transport patients. And so I think when I reflect on all of those it speaks to the core of why we're all here, right? Like, we as a hospital cannot make decisions independent of the communities that we serve. And so we need to get together and sort that out. And we as leaders, sometimes we make decisions that stretch our staff because, hey, we really want to care for these patients. But at the same time, I have always found it very valuable when I have a leader who can just be honest with me, right? So I think when we meet our teams, we just need to acknowledge that, yes, this is difficult, yes, this is not ideal, and just continue to provide those resources to our staff so that they can care for our patients as well.
Mary, do you want to say something about that?
No, that's really valuable. We just keep going on, kind of the Energizer Bunny. And, you do have to stop and reflect and say, I'm not okay today, or I need some help. And it's hard to acknowledge that, but we all need to do that, I think.
Do you feel like you've had days like that?
Some days, I drive around the state a lot, and I do. But again, I don't like to admit it. And I think some of that windshield time helps me kind of regroup and set my priorities. So, and also spending time in northern Minnesota and the metro is getting away. But not everybody can do that. Yeah.
But, I think we need to normalize that to our staff also. So when I'm with my leaders like Dr. Albright, and a lot of them are sitting here also, we have those difficult conversations. Mm-hmm. And when I sit with my peers and the group that I'm with, I feel like we need to normalize just acknowledging that this is difficult. And that way we can have more people feel comfortable to bring that up. So personally, I've appreciated being able to just know that I can call this person or call that person, or I can sit in the break room with a nurse or with another provider and just let it out my system.
Anybody else want to? Yes, ma'am, right back here. You'll introduce yourself?
Hi, my name is Rachel Palmer, and I work in the Division of Cardiovascular Surgery for Mayo Clinic. And admittedly, I do work in the psychiatry or child psychology. However, I am a parent, and I have experience with a child who has dealt with mental health issues during COVID. And I truly feel like a huge part of the care system of a child that is being overlooked is having mental health resources allotted to parents and allowing parents to attend either trainings or to meet just as a consult with a licensed physician or psychologist that does specialize in childcare, and just equip them with the tools that can be used at home to potentially help a child health mental crisis from exacerbating to a point where it is unrecoverable and the resources are not available at that point.
You have some personal experience with this, it sounds like.
I do, and I luckily was able to use the tools that I had learned during my daughter's counseling to help stop issues before they really remanifested again during distance learning and COVID. So I think that it is important as physicians and as caregivers to really involve parents in that system and to teach them as well as the patient how to cope with those issues.
Yes, sir.
I'll hold the mic. Yes, okay. Yeah, I'm Patrick O'Rourke with the Central Minnesota Dementia Community Action Network. We've actually implemented for our dementia family, patients, and caregivers and family members a mental health counseling aspect, dementia-informed counseling. And we found it was extremely important because so many of these relationships have been affected by the dementia situation within the family. And we went, United Way of Central Minnesota provided us with some funding to actually implement a mental health counseling component. We have seen just since August 1st, 7 clients in that area, but we have 17 in the queue to be seen. So it's quite a necessary component. Some relationships that are 50-year-old marriage relationships break down when one partner ends up with dementia, and so it's a real issue.
Wow, that sounds difficult. What have we missed tonight? we've covered, yes, ma'am. You were waiting for that question. It looks like, let me come right over here. I'll stand a little bit behind you, okay? And introduce yourself.
Thank you, Kerri. My name is Dory Walliff, and I'm a local resident. And I'm on a family council board locally here in Cannon Rivers. I have two parents, a 94-year-old and a 96-year-old, both in the facility. And today was a tough day. I wasn't sure I was going to be here tonight or not, but the caregiver, the adults, the kids, these are the journeys that we are taking. We've never been here before, and the support. I just see a big void for support for the adult kids. I see some heads being nodded in here because we all have family, we all have parents, we're all going to be there. And it's really heartbreaking sometimes on our family council. We want to be the voice for the people, the residents that don't have a voice or have loved ones there to be for them. Sometimes I just get put in there and the family kind of walks away and it's hard to see. But it's the adult kids and we're the ones that kind of need some help too.
Glad you made it. What else have we missed? Yes, sir.
I'm Ron Ziegler. I'm with Community and Economic Development Associates. I guess one of the things that I would like to bring up is that our organization, we are a 501c3. We do community and economic development for small communities. And I guess I'd like to bring up, when we're having these discussions, let's think about the very small communities as well. You know, we talk about the metro area, we talk about greater Minnesota, outstate Minnesota, but there's a third area that we preach as an organization, and that is rural. And when we define rural, we define it typically as 8,000 or under in population. So we have communities, 1,000 people, 2,000 people. And these are the people that, we want to try and keep the elderly in their homes. We want to try and keep them in their communities. Kaylin and Mitch work in a community called Goodhue, which is probably 30 miles from here. And there is a new elderly facility that's just opening now with 50 or 35 units, something like that. And one of the things that we are trying to look at as an organization is how do we provide services in the medical field to these very small communities. Once a community loses its school or loses its hospital, loses its clinic, it loses its will to live, so to speak. So we are trying to come up with ways to make that happen. And we realize as an organization and as a community that it isn't the medical community that's going to solve that issue. It's got to be us as a community that can solve it. So we're looking at different things right now, such as, maybe there's a mobile opportunity, in that elderly facility in Goodhue. Wouldn't it be something if a mobile transport clinic could show up there once a week, once a month, whatever it is, to keep those citizens in their community? So I think there's different areas to look at here. And again, we aren't looking at the medical side to solve this. We think it has to come from the private side and the community side.
I'm glad you came. A couple more comments, and then we can continue our conversations over there near the desserts. How about that?
Sure. Carissa Bugler, Director of Operations at Newell Medical Center, which is part of Allina Health. Just two quick topics. One is emergency medical transportation or medical services. In a lot of smaller communities surrounded by New Ulm, they are completely volunteer-led. They struggle with having access to education or trying to highlight the career opportunity to young people in their community who may consider moving back, but the training may be too far away or inaccessible. So that, I think that we need to talk about what is our funding source and reimbursement for transportation services and emergency response. In addition, I oversee the operations of our skilled nursing program out of New Ulm, and we've had 2 nursing homes, skilled nursing facilities closed within the last 12 months. And another nursing home that's trying to expand but shut down their capital campaign because they're very concerned about just, being able to stay afloat. So having access to those skilled beds, home hospital care, or having hospital-like services, but in the home is definitely something, but it's a small niche of patients that probably fit that. We need, once the patients, if they can't be cared for themselves, or if they're in assisted living or in a skilled nursing facility, supporting those organizations as well. That is something we need to be talking about and finding solutions for as well.
Yes, ma'am.
Oh, I just wanted to say, we've heard so many challenges and we've heard some creative opportunities, but in the midst of all of this, our healthcare organizations, the funding is going down, the financial outlook is not good for healthcare. And so we have to come up with creative solutions. We have to have forums like this to get people together to say, we can't count on the patients coming in and our reimbursement that we're currently doing, and something has to change and be different. We have to all get creative to figure this out.
When we started talking about the rural voice and what the topics would be, Tim, John, and Teresa and I, we knew we wanted to talk about rural healthcare from the beginning. And you all tonight have really validated why. Thank you so much for the benefit of your experience and your candor and your willingness to come and speak to this and kind of problem solve in real time and be honest about the challenges. We could go on, I know we could go on for another couple of hours, but I think there's more conversations to be held about this. I'm going to ask John to kind of wrap up. John, I'm curious about what you've heard and what you think about what you've heard.
Well, what I've heard, I think tonight is first and foremost, I've heard a new perspective. I'm more familiar from a patient perspective. My wife is here and she's representing her father, who's experiencing a $900 increase per month in his care in a rural town. How does he do that at age 93? That's real. That's here. That's now. Dory's here. She's trying to represent those in that similar spot. I've got a son here today. He works in a small town and he's trying to ensure that there's good, strong economic development in these communities. We didn't cover that so much tonight. He works at the local bank, but we can partner. We can do things. What I heard tonight is we've got to challenge ourselves to think differently ourselves. But I think you do too, we all do. We've got to start thinking a little differently about better solutions here. And we have to start thinking about those we serve, not about how we get funding. I can do that. How we need a better regulatory environment. Nobody's going to solve it for us. We've got to get better at being more strategic, more innovative, and smarter about how we do this. That's what I heard tonight. It wasn't so much about all that you said that are the problems. The question is, how are we going to solve this now? What are we going to do? So you have been getting after it for 30 years. I've been getting after it for 36 in my profession. We can't stop now. We can't get tired now. We've got to really get after this and try to be more innovative. Tim, I think we need to work together harder. I think we need to work together smarter. We're going to make some investments in some of our communities, small communities, Ron, that you just talked about, that are 1,000, 2,000, where they can't find pharmaceutical medication in the next 30 miles. We've got to change that. Mobile may be the right way. That's a great idea. Maybe we can do something there, Tim. But we've got to start thinking a little bit different. I don't know that we can solve it all tonight. I don't think we can solve it in the next week, but we can start somewhere, and we'll start maybe with that. Maybe we'll start with some different ideas. But all of you that didn't get a chance to say something tonight, I know you've got something that you want to say, and I hope that you know that we will hear you. Let us know what your thoughts are. Catch us at compeer.com, john.munson@compeer.com. We've got money. Not enough. But we can be smart and prioritize things, and we can make a difference one at a time. But that's what I heard tonight is we've got a chance to do things a little bit better. Bob, we got to get to work. Start thinking a little differently. We've got to start thinking smarter. Kerri, that's what I heard. Tim, what'd you hear?
No,
You're good. Okay.
Good.
It's quite a wrap up. All right, there is dessert and there's wine and beer, and please keep the conversation going. And thanks again.